Hi and good afternoon and welcome to this last in our series of webinars on drugs and COVID. I'm Nadine Ezard from the National Centre for Clinical Research in Emerging Drugs, and this series has been co-hosted by one of our consortium partners, the St Vincent's Hospital Alcohol and Drug Service here in Sydney, as well as the National Drug and Alcohol Research Centre in Sydney as well. And before we get going, I just want to pay my respects to the Gadigal people of the Eora Nation, the traditional owners of the land on which I'm seated here today, and pay my respects to elders past, present and emerging, and acknowledge that sovereignty was never ceded. Today, I'm really happy to have with me Rob Page, who's a GP based in Sydney, and he has worked in the last 6 years, focusing largely on providing quality primary care to marginalised populations, both in Sydney and in rural Australia. He has a keen interest in general practice and addiction medicine and holds postgraduate qualifications in public health, and is currently working towards fellowship with the Australian chapter of addiction medicine. So he's one of those good guys, the good GPs that we're really happy to be working with a real passionate interest in working with people with substance use disorders and people who use drugs that don't have substance use disorders to maintain health. So I'm really pleased that Rob could be here with us today to talk about what he's been seeing in general practice and what some of his colleagues might have been reporting for the way that GPs are changing the way that they deliver services during the COVID time, and now as we're entering perhaps an even more uncertain time with COVID. Certainly in Victoria, we're currently back in lockdown again, and in New South Wales we've sort of got some uncertain times ahead, I think, and the rest of Australia's in different positions. But what we have seen during the COVID time is a change in the way that people access treatment from GPs and a change in the way that GPs deliver their services, and also a change in the kind of things that people are probably seeking support for from GPs. So I wonder if you can just talk a little bit, Rob, about what those changes look like from the primary care perspective.
Yeah, absolutely. Thanks, Nadine. Yeah, it's been a huge 6 months for everyone, right? Both personally and professionally. For GPs, we've seen things change a lot, I guess, in the way that we practice that day to day, the social distancing stuff, the hygiene stuff, but getting access to all sorts of new sort of Medicare item numbers, being able to actually provide care for people over the phone and via video link and be remunerated for that. It's a big change. It's the sort of thing that people have been calling for a long time, and it's now happened, which is great, but it has forced us to look at how we provide care, how we assess who we can see in person and who we can see remotely. And it also impacts how and when and why people are getting in touch with GPs and actually coming in to see us, and referring specifically to those people who use drugs or who might use drugs in problematic ways. We're sort of just now looking at the evidence around, is this impacting when people come in to see us or when people come to see specialist services, the reasons that they're seeing us, and how they might be managing their drug use, their substance use, and managing their personal health otherwise. I mean, there's a bit of evidence already, as you're aware, around what this is doing to sort of drug use and drug markets, but the way in which people are accessing healthcare absolutely is changing. I mean, for GPs, certainly the number of people not coming into clinics has dramatically increased for consultations. Many people are using these sort of telehealth item numbers, and we're just sort of getting a feel for what that's doing to our clinical care and learning how to practice well under those conditions. So it's a really big change.
Have you got any sense of what that means for people who have substance use disorders that might be seeking treatment for the first time? Does it make it more or less accessible, or?
Look, I think it depends on the person, to be honest. I think certainly, I guess, having worked in Darlinghurst and King's Cross for a long time, having worked with many people who sort of are homeless or sleep rough, or who might not have good access to phones and to the internet and that sort of thing, who might not be able to access telehealth services, and then who are feeling that their GPs are trying to keep everyone at arm's length, they're certainly finding it difficult to access general practice services. But say for someone who might have a telephone or have the internet at home, or might have issues with substance use, but they have a roof over their head, they might find it easier to access their general practitioner because they don't have to sort of, get themselves all sharpened up and straightened up and get down to the general practice and sit in the waiting room potentially for half an hour or an hour. So I think it varies. I'd like to think that overall, like being able to access your GP with a phone call would make us easier to access, but some people can't do that, and some people aren't comfortable doing that for whatever reason.
Mm-hmm. And are you aware of any shifting patterns, people maybe changing the class of substance that they're using in the face of changing availabilities, or people requiring more prescription opioids or benzodiazepines or other prescription psychoactive substances? Is that anything that emerged there?
Yes, I suppose is the short answer. I mean, anecdotally, and I guess keeping in mind that I work in inner Sydney, people are reporting that it is harder to access methamphetamine, it's harder to access cocaine, heroin, sort of the type of heroin that people are accessing seems to be changing slightly over the last few months, and prices certainly.
In what way is it changing, Rob?
Oh, look, I've heard people referring to sort of like buying brown tar heroin rather than sort of like white powdered heroin, which is something that I guess I'd never really thought that much about, but it's interesting just from the point of view of, like, even if this is just a handful of people reporting it, what this might mean about, I guess, global drug supply patterns, local supply patterns, and yeah, this is just anecdote, right? So it might not reflect an overall pattern, but I think it speaks to bigger things happening.
And the brown tar heroin comes with different kind of risks to the white.
Yeah, look, I mean, that's the sort of question I think that an addiction specialist who's finished their training would be much better equipped than I would. But I'm going to say yes, it comes with different risks. Could I say that they're greater or lesser? I couldn't, I'm afraid. But yeah, like I think the changes in and of themselves, whenever someone talks about using a different substance or using a substance in a different way, we're always providing that harm reduction advice, right? About, look, just obviously if you're changing your patterns, safest not to use, but if you're using, start low, go slow, all these sort of things. It should be the reminder that we need to, even in people we might consider to be fairly au fait with illicit or non-illicit drugs, just letting them know that if you're changing your drug use, you maybe need to be aware of a whole different range of risks or potential harms with those substances. And I know though that in a more formal and non-anecdotal way, the folks over at NDARC are doing research which is sort of indicating that people who regularly use psychostimulants seem to be maybe using about the same amount or less of things like ecstasy or MDMA and cocaine, and hallucinogens, but maybe using a bit more cannabis and a bit more alcohol, and people certainly are purchasing more alcohol since the lockdown started. So I think there's, as well as the anecdote, there's some clear evidence of change in patterns there.
Mm-hmm.
Yeah.
So, and what do you think? So you've talked about some of the facilitators of coming to a GP. So maybe for some people a telephone call is easier than coming face to face. What are some of the barriers that people might experience in coming to a GP for treatment for a substance use disorder, or even if they're just not sure and they want to check up? What might be some of the barriers, and what have you done to kind of overcome those?
I think the barriers vary fairly significantly depending on where you live, as someone in the general populace. I mean, for example, I lived and worked up in northern New South Wales in Moree for a year, and the waiting list to come to see a drug and alcohol specialist, there was about 2 years or so, and the GPs up there had sort of varying levels of knowledge and experience around substance use, but there wasn't someone local who was comfortable prescribing methadone or buprenorphine, so opioid agonist therapy. So that's a huge barrier, right? I mean, in terms of being able to access that care that's likely to reduce risk significantly. In somewhere like Sydney, though, I mean, a lot of the research and evidence around people who use drugs in whatever fashion, seeing general practitioners, is this fear that GPs either aren't going to know what any of it's about and won't know themselves, or that GPs are going to discriminate against them or hold a certain amount of stigma around their behaviour. And the research, unfortunately, the research into clinicians kind of substantiates the fact that substance use, particularly illicit drug use, is still fairly stigmatized even amongst health workers. And I think that's a fairly huge barrier. It seems like the practices where the areas of practice exist in, if there's more drug use in a particular area, practitioners generally feel a bit more comfortable asking about illicit substance use. But in those areas where maybe it's not perceived that there are many people using illicit drugs, generally practitioners both won't ask about it, but will generally stigmatise a bit more around illicit drug use. And obviously that's not even mentioning alcohol and tobacco use.
I just remind people that if there's any question you'd like to share with us, I'll put it to Rob and we can try and answer them. So please don't hesitate to put questions now or later on. And if we don't get to them, we'll endeavour to put the answer up online. So Rob, you just mentioned before about stigma, which is an important barrier to treatment seeking, I would have thought. What are some of the things that you think that we can do collectively as a profession, I guess, to reduce some of those stigmatising attitudes?
Yeah, that's a really great question. I think that if we had a simple answer for it, we'd be doing a heap better. And look, don't get me wrong, I think over many sort of behaviours, we're doing heaps better these days than maybe we were sort of 3 or 4 decades or so ago. If we're talking about sort of stigma in a general sense, stigma about, I guess, alternative sexualities, and stigma about other sorts of behaviour that I guess aren't illegal at this point in time. But if we're talking about, I guess, illicit drug use in and of itself, we're talking about an illegal behaviour, right? So it'll have a certain amount of stigma around it because of that. I think that if we can, as clinicians, sort of start to work with those clinicians who are in training at the earliest stage possible, we'll do better in being able to get into people's minds that these are really important things before, I guess, people start to develop their strongly entrenched sort of patterns of practicing and maybe patterns of thinking and patterns of considering why people are who they are and how they are. I'd argue that stigma training and sort of marginalisation and discrimination training early on in the piece around all sorts of behaviours, but particularly substance use, would be really great. I mean, the folks at NADA and NUA have put together some excellent resources around sort of speaking with people about drug use and aiming to reduce stigma. And there's great resources out there, but I think getting it in front of people and getting people engaged around these things as early as possible will probably help the most. I think trying to convince someone who's maybe been practicing for 3 or 4 decades and convincing them to change their patterns of behaviour or patterns of thinking is going to be much tougher.
Are there some structural things maybe that could be, so not just anti-stigma training, but something at the structural level to make services more accessible? I mean, I know particularly in rural areas, there mightn't be the system. The primary care system is predicated on having a bulk billing GP, and there are many areas that don't have that person, and so they don't have continuity with that one person. So do you think there are other changes in the way we could actually set up primary care that are not so reliant on general practitioners as well? I'm asking you to do yourself out of a job here. No, I'm not.
No. Hey, like honestly, like I think I'm really biased. I think GPs generally do a great job. We do a tough job, but it's a great part of the health field to be a part of, because you get to provide this really great holistic comprehensive care. But at the same time, there are many other professionals out there, like sort of allied health professionals, like nurses, who can do a really great job in this space and in many other spaces too. I mean, at one of the practices I work at, we've got a specialist nurse who comes in once a week and who sees people who have issues with licit and illicit substance use. And that's fantastic. It sort of allows people who might not feel comfortable speaking with a doctor to speak with another really knowledgeable clinician who can then either link them to a GP or to a specialist service directly. In other clinics that I've worked in, like the health service I worked at in Moree, it was a public community health service, and they also had access to Aboriginal health workers and alcohol and drug workers, and that kind of approach gives people multiple entry points rather than just feeling like they maybe have to go and see this GP who maybe knows their whole family or has known their other various members of their community. Gives people, as I said, multiple entry points to come in, and potentially will allow them to avoid at least some of that perceived stigma that they might experience if they just have to go straight in and see the doctor, the boss of the practice there.
And peers, are you aware of any community health settings where peers are employed? Or
yeah, absolutely. That at a couple that I've worked at the Kirkton Road Centre. I think that I've worked there. I don't work there right at the moment. I worked there for a number of years. I think they run an excellent model there, and they've got peer workers there who do a bloody fantastic job. And I think that peer workers are a vital part of facilitating access to services but also allowing people to feel heard at whatever stage they might be at of engagement in treatment. And I think it's fairly well acknowledged that people might feel much more comfortable speaking with peers about issues that might be coming up than they would perhaps speaking to a clinician, where there's this either perceived stigma or perceived power differential or actual power differential that maybe is lessened through having peers or peer workers there. Yeah, no, you make a really good point. I should have mentioned in the first place. They're absolutely vital.
Yeah. And I guess one of the other challenges for many GPs is the coexistence of pain, chronic pain or pain syndromes, and substance use disorders, and sort of an inconsistency in managing that across different GPs. And I just wonder, particularly with the kind of de-prescribing movement, and maybe in the context of COVID where people have greater needs and less access, this seems like a perfect storm where people might actually be having their prescription opioids decreased when they mightn't benefit from that. And I mean, I wonder if you've come across any of those kind of issues during COVID. People really coming requesting prescription opioid drugs and being challenged with how best to respond. The reason I'm asking is I work on an advice line for GPs, and we get a lot of calls from GPs actually asking support for how to manage people with probably prescription opioid dependence and chronic pain syndromes, and it seems to be a challenge for many GPs.
Yeah, I mean, in the speaking that I've done with GPs around these issues, probably the most common questions that get presented are around how do I deal with people who are acutely substance intoxicated, and what do I do about doctor shoppers? They're probably the two most common questions that come out. And I guess speaking about, doctor shoppers obviously is a separate thing to chronic pain, but GPs, I think that's the part that people feel really tough, because they don't want to mismanage someone's chronic pain and potentially leave someone in the lurch and have their pain poorly managed, or throw someone into withdrawal. But at the same time, they don't want to facilitate people who they perceive as prescription shopping, and they get this sort of stuck in this really difficult situation where they want to help someone, but they're fearful of either facilitating prescription shopping or getting done by regulators for prescribing inappropriately. And I think this is a really long-standing issue. This was there before COVID. And I think obviously it's a coincidence of timing, but just recently they've changed the amount of tablets in a packet of many Schedule 8 opioid drugs, so that if someone is prescribing those drugs, the automatic amount that someone is given is typically much smaller than before. And I think that's a good step to sort of discourage people from giving large amount of opioids at a time. In terms of what it means, though, for people seeking help for their chronic pain during these times, or for using pharmaceutical opioids, it's a really difficult thing, particularly if you have someone that you're potentially seeing via video link or over the phone. You're trying to do an assessment of pain, which can be difficult at the best of times for a GP, let alone a specialist. And then trying to provide advice around that situation. I mean, you run the risk of someone's pain inadequately being controlled, or them going into a withdrawal if you potentially don't prescribe something. But if you do, there's always that fear around regulatory bodies getting stuck into you for prescribing inappropriately, or having someone either take medications and have it overdose, or sell them on and someone else suffer harms. I mean, it's a tough situation. And I think, yeah, it existed before COVID, it still exists now. And I think having better linkages to addiction services and pain services for GPs is what many GPs really want. Regardless of that, though, I think it's going to be a tough thing across the board.
Right. So I've got anti-stigma training, better linkages to specialists, interdisciplinary community care models, and peers as a way of improving care, and continuation of the telehealth model. So they're kind of the things we've covered off on for COVID. I've got a great question here from Tim. I work in an NSP, and I have felt significantly limited in terms of our ability to provide further services, e.g. brief interventions, bloodborne virus testing, etc., due to having to focus on maintaining social distancing. Clients also appear less interested in engaging. What has been your experience of adapting your service while maintaining good COVID protocols? It's a great question. So the things we wanted to do, and we did them well. how do we do them at 1.5 meters?
Yeah, it's a really tough thing, right? I mean, particularly things like doing bloodborne infection screening. I mean, you've got to come pretty close to someone to take some blood
Yeah.
from them. I mean, I know that at least in New South Wales, I think it is just a New South Wales thing. We've got this access to being able to have people posted out dried blood spot test kits, so they can then do a dried blood spot test at home and post it back in. I think it's a fantastic movement, and I think that sort of thing should absolutely.
For which viruses, Rob?
Sorry, apologies. That's for HIV and hepatitis C.
Let's see. Yeah.
Yeah, and so you'll get your response back within a couple of weeks and know whether or not you have either of those infections. And I think that to expand that type of thing it's fantastic in a general sense and kind of circumvents some of those COVID issues. But I suppose, like being able to engage with people and have them sit down in a room with you, or even just have a conversation with you about harm reduction or about other clinical things you might want to do, checking blood pressures, they're really tough. I mean, I think that in a general sense, we want to make sure that people are still getting those sort of good community primary care things done, like having the blood pressures checked, like being able to speak with people about their tobacco use or provide NRT, like doing bloodborne infection screening. And I think that if COVID restrictions are going to be going on for another sort of 3, 6, 12, 24 months, I mean, who knows? We can't just be avoiding all of those things. We've got to find ways to do them that will still minimize the risk of transmission. So if that means whatever it might be, sort of appropriately positioning people so they're facing away from you, ensuring really good hygiene at all times. Using masks if appropriate to the clinical situation. I think we should still be maintaining the good primary care that we need to, because if we don't over the next couple of years, then we might be missing those people with diabetes, with high cholesterol, with high blood pressure, and then in the long term seeing greater rates of heart disease or cancer or these other sorts of things. So it's a tough balance though, because you've really got to judge the situation, each situation in itself.
And it does seem that historically in times of crisis, we abandon our preventive care programs. And the longer that goes on, the bigger chunk of a population will have missed. So I guess if that's the question, is how do we reinstate those or maintain them, or even encourage people to consider it a priority when there are other far more acute competing priorities, particularly if people are concerned about contracting an acute.
I mean, I guess you're right. As clinicians, we can want to do these things all we want, but to have service users wanting to engage around them, it's tough, right? I mean, it's like any conversation that we need to meet people where they are to a certain extent, and if they have competing priorities and other things are priorities at that time, then it's absolutely fine for people to decline to engage about certain things. But I think it is important that as good clinicians that we do continue to have the conversations and encourage people to engage about these things and explain why it's important to do so. So once people are again ready to engage, that we're able to jump on those opportunities and take advantage where we can.
Yeah. Okay. What are your 3 hot tips for GPs who want to work with people who use substances?
Really, I think they're pretty simple, to be honest. I think the first one is maybe the toughest one. I don't think it's that tough. It's really just to know enough about what you're asking about. I mean, I think generally as GPs, we're good at asking about tobacco. I think we're good at asking about alcohol, but asking about other drugs as well, it's not too much of a stretch. And just to sort of know the name of a handful of things that might be commonly used in your area, or that might be the most commonly used things in Australia, to ask specifically about them, I think it's important. So just to be asking about these things regularly, you might be surprised by the answers someone gives you. I mean, I had a 71-year-old bloke in my general practice 18 months ago that I didn't expect him to answer yes to any of the illicit drug questions, but I asked him because I always do. And he's been injecting speed daily for the last 30 years. And that was unexpected, but I found out about his hepatitis C as a result. So firstly, knowing enough about it to feel comfortable asking about it, and then get comfortable asking about these things and do it routinely with all of your new patients, because if you don't ask people about it, then you're never going to find out and be able to intervene. And then once you've asked the question, I guess, know what to do with it and know who you have to help you. So if you find out that someone's taken drugs a couple of times in the last year, is it necessarily then to say that this person has a drug problem and we need to tell them to stop? Perhaps or perhaps not. I mean, there's this wide spectrum of drug use, all the way from sort of severe dependent use with multiple problems to occasional use with few or perhaps no problems. And I guess knowing where you might need to either intervene and refer to treatment or give harm reduction advice or sort of encourage decreased use. But if you know who you've got around you to help you, if you're unsure about any of that, then I think that's my final key point. So knowing if you have a local champion at your general practice, or if you've got a specialist nurse nearby, or if you've got a phone number that you can phone up, like the specialist advisory service, or what resources you might have online. Just knowing there are many services in most places, but not all, that you could contact to ask for further advice. Because yeah, look, as GPs, we know lots about a lot of things, but there are some things that we don't have our head quite around. And if you don't, that's okay. But I think just make sure that you know who you can ask about it and then do so.
So you mentioned some resources already, and we will put these on the web. You mentioned the newer and the NADA kind of anti-stigma resources that are out there. You just mentioned the specialist advisory line, and there most states and territories have a specialist advisory line for health professionals. So we can put those links there. Are there any other kind of great resources that you'd recommend for GPs or other primary care practitioners?
Yeah, absolutely. I mean, there's quite a lot of them out there, and the local ones that I really like, there's a service called Turning Point down in Victoria, and they've put together some excellent resources, both on substances themselves, but also treatment resources that are really very comprehensive. So I like those ones. Insight's another service that's put some excellent resources together, and again, they're very comprehensive.
They're in Queensland, hey?
That's right. Yeah. ADF. Oh God, I don't even know what it stands for. Australian Drug Foundation.
Foundation.
Yeah. Their resources are really very good too, and I think New South Wales based is Your Room, and I really like those ones too.
Right.
And I think the good stuff about Your Room is that many of them seem to be targeted at service users too, so people have the ability to learn about substances themselves. And I think NCRED, if I'm not incorrect, might have put something together not so long ago.
Yeah, we've got some reasons. I mean, I guess maybe just we've got a couple of minutes left. I thought it might be worth just talking through the Insight tool that I think some GPs find quite useful in helping people set goals or go through a sort of a structured brief intervention with them. Do you want to just run through what that tool is and why it might be useful? If you know what I'm talking about.
I don't, in fact, I'm sorry. Okay. I've done a couple of the Insight online courses, but they're really sort of just comprehensive courses explaining about drug use. I'm sorry, I don't know that particular tool.
Okay, that's all right. No, they've got a brief methamphetamine intervention for primary care, for a range. It can be used in a range of settings, but it's just to help people structure their brief interventions with somebody if you're new to doing brief interventions, or you want some structured tool for people to fill out and take home and have a look at. So it's just, some GPs tell me it's a useful tool for them to use with clients. And there's a couple of online things that people can start filling out. We're actually doing an app. We're studying an app to see if that can help people set goals, track use, and understand if there are any harms associated with their use, because we know not everyone will go to their GP to get a checkup. So having a sort of lower threshold kind of intervention for people before they come, or even to promote going to a GP if they want to ask for some help. Yeah, no, I think it's great, honestly. Expanding the number of resources that are out there, I think, is vital. And I suppose one other thing that I'm not sure if there are going to be so many GPs listening to this. Hopefully there's a couple at least. but I think that in addition to being able to refer to those resources or refer to specialist services, we should always remember that even just asking about these things and providing some sort of brief and structured advice, it does have an impact on the way that people use substances, be it alcohol or tobacco or illicit drugs. And typically, if people are engaged in substance treatment and they have a GP along the way, just having a GP they're seeing regularly through that and managing comorbidities leads to greater rates of remission of substance use and to less harmful use. I mean, I think
the work that we do is really valuable. And I think it's important that we kind of abandon that therapeutic nihilism that some people describe, where if we put all this effort into people who use drugs and they never change and they keep on doing bad things and they just doing it to themselves. I think if we get away from that way of looking at things and just continue the sort of gently approach that we have, where we provide the best care that we can to the people as they approach us and help them through the stage that we're at. If we do that for people with issues around substance use in the same way that we might for people around issues with whatever it might be, mental health or diabetes, then we do get progress, particularly across big populations. So it's important to remember that, I think.
Thanks, Rob. That is just a fabulous way to finish this webinar. Just to really sums up what I think is excellent quality primary care. So thank you very much for joining us today.
No worries. Thanks for having me today.
Thank you.
Cheers.
Cheers.